Joe Mullings from 160 Studios in Delray Beach, and I've got David Nauer from Sonavex in today. David, good to see you.
Good to see you. Thanks for having me, Joe.
Yeah, these are your old stomping grounds I just found out today.
That's right. Grandparents used to live here, come down to Jog Road, play a lot of tennis. It was a lot of fun.
Nice. Now, Sonavex, you have been super active with that organization over the last couple of years. You and I first started chatting with each other a few years ago, sort of maybe when the technology first came out. So for our viewers, a little bit about Sonavex and what the intention of the tech was.
For sure. Yeah, so Sonavex came out of work that I'd done in grad school with a physician and a professor. I was in school for biomedical engineering, met a physician who basically said, hey, look, there are a bunch of different surgeries that we do where we tie two ends of a blood vessel together. It's called a vascular anastomosis. Now for him, he was in reconstructive surgery, and he said, the reason I do these vascular anastomoses is I move tissue around. It might be a cancer patient, it might be a trauma patient, but hey, they're missing a body part and we need to fill that defect. So in his practice, he'll take tissue that's not critical in another part of the body and then use that to fill that defect and restore form and function. They're pretty crazy procedures, 8 to 12 hours long, really cool stuff to see. So he said, one of the big problems here is that at that junction where I make that connection of the veins or the arteries, there's a high risk of a problem afterwards. And if we can detect that problem early enough, we can solve it. And if it's too late, it's a big issue. It's a big issue for the patient. It's a big issue for me, and the hospital's out a ton of cash for it. So we started thinking, okay, how can we make this problem better? How can we alleviate the situation? We came into a solution space in the imaging realm where we basically thought of the idea of, hey, if we could use ultrasound and enable people that are at the bedside taking care of these patients who are not trained sonographers and where it's not practical to have a trained sonographer available, we could give them the ability to collect this information. We're going to be able to make a big impact. So fortunately at Hopkins, a professor who's world-renowned for his expertise in medical image analysis, including in ultrasound, happened to be down the hall. We introduced our goals with him, and we were able to say, hey, look, here's what we're trying to accomplish. Are we crazy? He said, only a little bit. I think we can figure this out together. So the three of us partnered originally within the university and then ended up forming Sonavex around that technology a couple years later. But the whole idea is that our technology enables someone without any background in imaging to be able to get a very short introduction to the solution and be able to collect vascular lab quality ultrasound exams in a matter of seconds with no specific training. And though the original motivation for this technology was in this reconstructive surgery arena, we very quickly realized that, hey, there are a lot of other types of procedures that you have to tie two ends of a blood vessel together. And there were 4 that we felt were towards the top of that list, and another one was the dialysis access market for dialysis patients that require an AV fistula to be able to deliver dialysis, and that's the area where we spend most of our time focusing.
So tell me a bit about how does that solve a problem? What's the risk case with the patient? What's the data to support that? And what is the current status of the dialysis market and the risks to it? Because we shared some conversations before we sat here, and I was pretty floored on what you were able to accomplish with Sonavex.
For sure. Well, thanks for that, Joe. It was very interesting to see that the dialysis market evolved in a parallel track to our business's evolution. And we were fortunate to get some key advisors early on to help us get some of the inside scoop and pay close attention to it so that we could sort of adapt with those market dynamics that were changing. So basically the macro for the dialysis opportunity is that within the next few years, there will be 5 million patients on dialysis. The primary method of getting dialysis is hemodialysis. And in order to get hemodialysis, you need to figure out a way to get your blood from your body into a dialysis machine, cleaned, and then back into your body. So that's called your dialysis access or vascular access. 80% of patients in this country start with what's called a central venous catheter. So this is a tube that goes from your neck to your heart. It is where 80% of patients begin, though it's by far the worst option for patients. And the reason it's so bad for patients is that the mortality risk is 2 to 3 times greater than any form of other form of access. The risk of hospitalization due to a bloodstream infection happens on average twice per year, and it costs about $22,000 an instance. And then 3 or 4 times a year, the catheter gets clogged and has to be replaced. So when you look at the macro here, Medicare spends $28 billion a year on end-stage renal disease. A primary driver of that cost is the vascular access, and catheters are the major culprit for those costs. So you must think, okay, how do we get the patient off of a catheter onto another way to deliver dialysis? So there are 2 other options. One's called an AV graft, which stands for an arteriovenous graft. This is a synthetic tube connecting a vein to an artery in the arm. This is better than a catheter because the mortality risk is way lower, but they tend to clot off very frequently. They're expensive to maintain, and you don't want to put that foreign material touching the blood if you don't have to. The best option, if the patient's eligible, is called an AV fistula. So this is, again, it stands for an arteriovenous fistula. This is where you connect a vein to an artery somewhere in the arm. It can be the lower arm or the upper arm. However, before you can use the fistula for dialysis, it has to undergo this natural process called maturation. And that's where the vein will basically expand in diameter. It accommodates a higher volumetric flow rate that's necessary to get your blood out of the body into the dialysis machine in a reasonable amount of time, clean and then back in. And it also has to get big enough so that the dialysis techs can actually get the needle into it. And when you look at the data right now, though AV fistulas are the preferred method, best for the patient, best for the payer, one of the big limitations is that it takes, for half of the patients, more than 6 months from the original creation of the fistula until you can actually use it for dialysis.
So what do you do in that meantime?
In the meantime, you're stuck in your dialysis through the catheter.
Which is a high-risk situation.
High-risk situation, bad for the patient, and a major driver of costs. So at Sonavex, we realized that there was a really big opportunity to be able to use our technology to get patients onto their fistulas sooner and get those catheters out. And this sort of evolved as the technology was evolving. There was a major study that was funded by the NIH that was meant to understand why are so many of these fistulas failing and why are they taking so long. And the thesis behind the paper that summarized a 600+ patient study is that 3 ultrasound parameters, volumetric flow rate, diameter, and depth, as early as 2 weeks after the surgery is created, can tell you what's going to happen with that fistula. So we now were able to say, look, these ultrasound parameters that our technology can very easily provide have a meaningful impact on these patients, and it's something that can, really impact their lives, but also reduce the complications associated with these catheters. And when we looked further and we said, okay, well, look, ultrasound's been around for a while. Why isn't it being used routinely here? And what you realize is that in order to assess the status of a fistula, you either need to be a physician and do a physical exam, or you need to have a duplex ultrasound done. And this is done by trained, registered vascular technologists in a vascular lab. These patients, they live pretty tough lives. And we didn't realize that at first, but they're going to the dialysis clinic, most of them 3 times a week, 4 hours a day, and maybe they're trying to hold a job, maybe they're unable to have access to transportation, sometimes they don't have economic means to pay for the gas money the ultrasound lab might be 60 miles away. And it's just another challenge for these patients to go see the physician again, to go get that ultrasound. And you're not gonna get your answer that first time. You might need to go back every week, every 2 weeks, until you get to that point where the fistula is mature. So our aha moment was, hey, well, what if we can meet the patient where they are? What if we enable the people that are already touching these patients 3 times a week
In a dialysis clinic.
the dialysis clinic to get this information and have that transmitted to the nephrologist and surgeon to make the right decision. And that was the aha moment that resonated with the community and was what really enabled us to see how this technology could fit into this dialysis market in a really attractive way.
So we've seen this happen across the healthcare industry as the changing centers of care. And the changing centers of care may remain geographically the same in some cases, but change who's in that center is what you're talking about, right? Because I don't need a trained sonographer necessarily. This sounds like it can be in the hands of the clinician who's there already. And so what's the resistance to that? What's the clinical data? What can you share with us on how is that impacting evidence-based so far with the product?
Yeah, so the best thing to point to is right now there's existing ultrasound criteria that drive decision-making. And there's this big set of guidelines called the KDOQI guidelines for vascular access. It's a massive document, and our chief medical officer was one of the co-chairs, and it's published every several years to basically say, hey, how do you manage these patients most efficiently? And basically there's consensus that there is they call it the rule of 5s or rule of 6s, depending on who you ask, where you have to say, hey, look, is your volumetric flow rate 500 mils per minute or more? Is your diameter 5 millimeters or greater? And is your depth within 5 millimeters of the surface? And what everyone wants to be able to see is that with this new solution, I can have confidence that my numbers can map to that criteria, because that's how I'm gonna make my decision. So what we set up was a head-to-head study where we were looking at EchoSure, our imaging solution that works with our implantable device called EchoMark, that's bioresorbable. When you put that in the hands of the profile of the people in the dialysis clinic, so a dialysis tech or even a nurse, how do those numbers compare to the best we have now, which is conventional ultrasound? So it was over 5,000 data points. We had 25 participants, and we were able to look at the various morphologies and flow rates expected in the maturation phase of an AV fistula. And we were able to show really some very compelling results that were just accepted for publication in the Journal of Vascular Access. And basically, the take-home point was that the accuracy of EchoShore in the hands of these inexpert users, the people that have never touched an imaging device before, were as good or better than the duplex. And then what we were expecting is that the coefficient of variation, meaning how much can you actually rely on this number, how precise is it, was far better than conventional ultrasound. And the reason that we're able to do that is that regular ultrasound requires a number of very manual processes, and even if you're trained in it, they're so manual that there's a lot of error in many steps of the process. And our implantable fiducial, plus the algorithms that were originally developed at Hopkins and then further advanced within Sonavex, are able to take away all of that human error algorithmically. So we were able to see much greater precision, and that data will be published hopefully within the next few months in the Journal of Vascular.
There's also a lot of oversight right now in the dialysis market and the way people are going to be paid and the impact to the current business models. How does this fit into that?
Yeah, so that's another thing that's evolved along with the technology that we've been paying close attention to. So the newest program from Medicare in this shared cost model or value-based care, whatever name you want to call it, is called the Kidney Care Choices Program. Many people call it CKCC. Traditionally, all these problems we were talking about, that $28 billion that Medicare was spending, Medicare was responsible. If your patient has to get hospitalized for 11 days for an infection, not great, but really not my problem. Now, all of a sudden, the responsibilities for those financial implications of these issues are starting to fall on some different folks. So you'll have your dialysis organizations that partner with nephrology groups in these CKCC organizations that are now starting to feel some of that impact. And it's very new. It started January of 2022. There was a former iteration that sort of formed the basis for this active one, but the bottom line is now other folks are responsible for these impacts. So what we're seeing is that a lot of physicians and other providers are trying to figure out, okay, some of these costs that we know are coming, how do we defend against them? And it's been very clear that these folks have identified certain limitations in their existing care. One of which is, how do I get an ultrasound, or how do I get a physician to put their hand on an arm? And these nephrologists, like I said, there will be 5 million patients on dialysis in the next couple of years. There aren't that many nephrologists. So there needs to be technology to give them the data they need to make decisions when they can't be there. And you know what, there aren't sonographers everywhere as well. So they've seen this as a great solution to fit into a known workflow issue that was bad for the patient currently, but didn't feel their pockets and their practice as strong. And now, as of this year, and it will become a greater percentage of overall patients in the coming years, this is a solution that can really not only help the lives of patients, but also have their businesses operate more efficiently and enable them to deliver better care at a better price.
So where's Sonavex today? I know you and I have been chatting about, you were down here chatting with investors. I'm going to see you added LSI. Where do you sit today, and what would you share with our audience?
Sure. So in terms of the stage that we're at, we've been able to achieve FDA clearance with general indications for both our implantable EchoMark solution and our EchoShore solution. So we validated the performance of that technology, and right now what we're focused on is specific indications with the FDA related to this dialysis patient population. So we have 2 clinical trials ahead of us, one of which we've begun, another we intend to begin later this year, that will really demonstrate those clinical benefits that we, our clinician advisory board, and many of the collaborators we work with are very excited about. In order to get through this next really exciting time for the company, we have been able to fund the business through a number of different strategies. We've had substantial past funding, but right now we have a $5 million financing active. Just recently closed the first tranche of $2.3 million of that, and we haven't announced it publicly yet, but there was a $1.7 million grant from the NIH to fund a pipeline product that is also related to this dialysis patient population. So money coming in both from dilutive and non-dilutive sources to fund this really exciting clinical stage of the business and collect some pretty compelling data to demonstrate that value of the technology.
And so what's the end point here? Is that those trials that you plan on running for safety and efficacy, of course, where do you go from here? Is this potentially, assuming you don't hit headwinds, 12 months out, 24 months out?
So we'll have results from the first study this calendar year, and those will be shared within the year as well. The 300-ish patient randomized controlled trial, I can't speak to any sort of specific timelines at this point, but we're hoping we'll be able to share some outcomes data this year.
Yeah, getting 300 patients in a dialysis study is not a hard thing given the massive impact that disease is having in our country.
Well, you see some of our sites do 300 to 600 of these eligible cases a year. So, 300 patients for any standard clinical trial is often seen as a daunting task, but fortunately, there's no shortage of patients for this study.
Yeah, good. Well, exciting stuff for you. I'm glad you were making it down here to the sunshine and visiting us here. And you're in town for a couple days?
That's right. Yeah, here through tomorrow.
Okay, great. And then I'll see you out in Southern Cal in a couple weeks.
Looking forward to it. Thanks for having me, Joe.
Thanks for sharing the information. That's Joe Mullings from 160 Studios with David Narrow and Sonavex. Be well.